Thank you so much for having me. So I'm Dr. Julie Greenberg. I'm going to be talking about treating the root cause of acne, the gut-skin connection. So I'm a licensed naturopathic doctor, registered herbalist, and this is where I hold degrees from. All right, so I just want to say thank you guys for joining me. I know all of our time is really busy, so I appreciate it. I'm going to try to give you lots of good information over this next hour. I'll be taking questions at the end. So, acne. Obviously, there's lots of conventional ways to treat acne, and that is by addressing symptoms, right? We're going to try to like shove the inflammation and the pimples back down. But that's not what we want to do as functional medicine and naturopathic doctors. We want to get down deep into the root causes, figure out like why and how is the body malfunctioning, and clean it up at that root cause level. Then we're actually treating the root cause and helping the patient so that they no longer need to be taking medications and they don't need to be taking suppressive medications. So I do this by using the gut-skin connection. We know that gut dysbiosis is a main driver of systemic inflammation, and chronic dermatologic disease is systemic inflammation. You're going to see this. So by going back to the gut and treating the issues in the gut, we can treat the skin at this root cause level, and we can do this with acne. So we test and treat the gut. I'll be going through 2 case studies in a little bit for you guys, showing how to actually put this into play. I'm a really kind of like tactical and practical person. I don't want to just hear the theory. The theory and the science is nice, but I want to see it, in clinic. How do you apply it? How does it work? So we're going to be looking at 2 different case studies in a bit. But first, let's talk a little bit about the gut microbiome. So I'm sure you guys know, the average adult human has 3 to 5 pounds of microbes living in their gut. That's a lot of microbes. I mean, when you step on the scale, thinking that 3 to 5 pounds of that is not even you, I think it's pretty astounding. And we don't just house them for free, we feed them for free. Why do we do this? Why do we have these gut microbes? What do we get out of this arrangement? Of course, the answer is we have co-evolved with them. We can't survive without them. They can't survive without us. They make things we need, things like butyrate, which are short-chain fatty acids. They crowd out pathogenic microbes. They maintain a healthy ecosystem in the gut. Of course, they regulate the immune system. I mean, at this point, I feel like, every day, every week, there's new research on what the gut microbiome is impacting in our body. It's really everything. And there's a lot of microbes in the gut. We think trillions of organisms are living in the gut. Bacteria is certainly the leader in terms of numbers, but there's also a lot of fungal elements, viruses, archaea, bacteriophages, protozoa, worms, all sorts of organisms. So we want to pay attention to the bacteria, but we want to know about what else is going on as well. And that is why I test and treat the gut for all of my derm patients, not just for acne, but certainly also all the acne ones. First, I want to assess their digestive function. Is their stomach acid working? Is there enough bile? Are there enough digestive enzymes? When we look at how much of the body is dedicated to digesting and processing food and extracting nutrients, we can see it's pretty important. And then, of course, the microbiome. And I actually start with the oral microbiome. So I ask all of my patients about their oral health. How often do you see a dentist? Any dental or gum disease, root canals? Do you floss? How often? Because this is obviously the starting point of the digestive tract and is going to impact everything afterwards. And then with the GI map stool testing, we can see what's actually going on in the gut. So I think, probably if you guys are on here, you know what functional medicine tests are, but if you're a little bit new to this and you're just checking this out for the first time, there are numerous different tests that we use in functional medicine. For me, I have a GI map done on every patient who walks through my door, as well as an organic acid profile. So everybody is getting these done. And then I use a variety of other functional medicine tests as well, things like hormone testing, mycotoxin testing, and other things. But the baseline is the stool test and an organic acid panel. And why I really love stool testing is it gives me information about both the pathogens and the commensal organisms in the gut. So we get H. pylori. The GI map becomes standard with H. pylori, and that's pretty unique. It's one of the reasons I love it. We get all the normal kind of commensal bacteria, opportunistic pathogens, and again, we'll be looking at some stool test results in my patients. some information if there's fungal or yeast elements, parasites like protozoa and worms. We're going to be talking a lot about protozoa and H. pylori as it relates to acne. Viruses, digestive markers like steatocrit. Steatocrit is going to tell you how much fat is in the stool, and elastase, of course, is a pancreatic enzyme. We're going to be looking at these in some of the case studies. Inflammatory markers, things like calprotectin and secretory IgA. Permeability markers, you can order a zonulin. So there's just a lot of really robust, great information from the stool test, from the GI map. And then I use these results as my roadmap. So I know, we've got all this acne. Now I can see all the dysfunction in the gut, and I know that by addressing that gut dysfunction, that's going to be my roadmap to clearance, and we'll see that. All right, so let's talk about acne. And whenever, my goal is always to find and treat the root cause of any dermatologic disease that I'm treating. And you have to start with the pathophysiology. So let's look at what's actually happening with acne in the skin that's physically creating the acne. So the kickoff point for acne is always going to be excess sebum production. Sebum is a lipid or an oil. And if you're not familiar with it, let's look at the hair follicle here. So we see a hair follicle, and then we see a sebaceous gland, this yellow stuff on either side. The sebaceous gland is what is responsible for producing sebum, and sebocytes are the cells within the sebaceous gland that produce the sebum. Sebum is a good thing. We like sebum. It helps lubricate the hair. If you can imagine a hair growing, it starts down here and then it has to travel up and through the hair follicle to come out as a new hair. Sebum lubricates that hair follicle pathway. It also comes out and lubricates and moisturizes our skin, right? So we have natural moisturizer, which is sebum. So sebum is good, but when there's excess sebum production down here, that is the kickoff point for acne. Then after that, what happens is we can get an overproduction of skin and accumulation of dead skin cells and sebum. So we can see there's kind of like a gumming up of the process. Then that can potentially clog up the hair follicle. We don't want that, because then we can get overgrowth. There can be bacterial acne. So bacterial overgrowth of acne, the organism usually responsible is C. acnes or Cutibacterium acnes. We used to call it P. acnes or Propionibacterium acnes, but it's the same thing. So whether it's P or C. acnes, it's the same organism, it was just renamed. There's also fungal acne though, and you can get fungal overgrowth of Malassezia. Malassezia is a yeast, it's a commensal yeast that lives on all of us, and it can get down there and trapped. And these organisms can feed off of that kind of gummed up, clumpy sebum and skin cells. So that's what's going to drive the creation of acne. Now, what are the triggers of acne? So many, right? And of course, our Western diet, our SAD, standard American diet. We're going to talk more about this, but what do we love most in our diet? Meat, wheat, dairy, and sugar, right? Those are staples of our diet. We're going to see that excess hormones, of course, testosterone and things like insulin, they're going to drive that sebum production. Pressure. So we used to worry about chin strap acne and things like high school wrestlers, but of course, now after COVID, there's a new thing called maskne that's real, and people were getting a lot of acne underneath their masks. Medication, so birth control pills can go either way. For some women, it helps clean up their acne. For other women, it can bring on an explosion of acne where they never had it before. Steroids also tend to create acne. Stress, of course, is a trigger for, I think, all chronic disease, but including acne. Overconsumption of certain substances or vitamins, so fluoride, vitamin B12 in high doses, or biotin in high doses has been found to cause acne. And of course, cosmetics, comedogenics, things that we put on the skin that clog or occlude the skin, then that can also create acne. So there's a lot of things to be thinking about. But what is the driver of all this, right? We saw, okay, that the mechanical action is that we get an overproduction of sebum and an overproduction of skin cells. Well, what is driving that? And for that root cause, we have to look to something called the mTOR pathway. That stands for mammalian target of rapamycin. And there's two complexes that we know of. There's mTOR complex 1 and mTOR complex 2. We know a lot more about complex 1 right now. We're still learning more about complex 2. But when we see, well, what is mTOR complex 1 responsible for? cell growth, cell metabolism, lipid synthesis. Lipids are sebum, so sebum production and sebum metabolism, and protein synthesis. Skin is a protein. So those first two kickoff points in acne, overproduction of sebum, overproduction of skin cells, mTOR is what is responsible for that. Now, mTOR is, again, it's a growth pathway, so it's a good thing, right? We need to grow sometimes, but it needs to be kept in check. So what are the things that are going to take mTOR and kind of push it out of control and then push on it too hard to create overproduction of sebum or skin? Well, right now we're looking at a cell. So this is the phosphobilipid layer. So this is the border of the cell. This area here is the cytoplasm, and here is the nucleus. So these are external factors, and we're looking at what would push on and make mTOR go too hard. Insulin or insulin-like growth factor, right? These are kind of, anabolic things telling the body to go build. Any sort of growth factor, like the growth factor of puberty. Glucose, again, it's a food source, it's sugar telling the body it's go time, let's go build things. And in particular, the amino acid leucine is the amino acid that tends to push the hardest on the mTOR pathway. And inflammation. Inflammation will signal mTOR that it is go time. So all of these things are going to push on that mTOR pathway and result in excess production of sebum and skin cells. Now, of course, there's always like a yin and a yang in the body. And so, if mTOR is the growth pathway, there's something to control it, and that is FoxO1. So here's FoxO1. We see FoxO1 is doing this dance, and it can move into the nucleus, and then it can move out into the cytoplasm. And this is very important where FoxO1 is, and we'll see why. But FoxO1 is there to help kind of balance out and control mTOR and make sure that there's appropriate growth, but not inappropriate growth. So FoxO1 functions, it inhibits hepatic insulin-like growth factor 1. It inhibits lipogenesis, sebum production, suppresses androgen signaling, so it's going to keep that kind of testosterone androgen piece in check, reduces oxidative stress, right? So counterbalance to inflammation, and it controls antimicrobial peptide synthesis, so how we fight organisms like C. acnes or malassezia. So FoxO1 is your friend if you have acne. And FoxO1 is an mTOR inhibitor. But remember, we saw the dance of FoxO1, sometimes in the cytoplasm, sometimes in the nucleus. Very, very important, because FoxO1 is inhibited in the cytoplasm. So when it's phosphorylated, it gets kicked out of the nucleus, out into the cytoplasm, and that's kind of like a penalty box for FoxO1. It can't do anything there. It can't downregulate mTOR and keep it in check. But when FoxO1 moves into the nucleus, it is activated, it's dephosphorylated, and now it can do its job. It can downregulate mTOR and make sure that mTOR isn't going crazy. So we need this appropriate interplay between FoxO1 and mTOR so that mTOR doesn't get out of control and drive the acne process. All right, let's look at the prevalence of acne in our culture. So teens, I think we all know, it kind of feels like it's always been, no, teens are going to get acne. And over 85% of American teens are affected by acne. Males a little bit more than females because males are having a surge of testosterone. But I mean, up to 80% of high school female patients, people are also going to have acne. So it's pretty widespread. And it used to be very much that it was a disease of teens. When I was growing up, really not that many adults suffered from acne. That is not the case anymore. The numbers of adult acne patients are on the rise, and I actually see more adult acne patients than teens even. Up to 65% of women who menstruate report onset of acne prior to menses. But it's not just women. There's low-grade persistent acne in up to 40 to 55% of men and women ages 20 to 40. So it's not like it used to be where you kind of go through puberty and like, okay, this wasn't great, but you're going to outgrow it. No, it's persisting, or even we're getting a lot of adult onset acne. And even women in their 40s, up to 12 to 25% are still dealing with acne. And I have a couple of 50-year-old patients, and they're so frustrated. They're like, I don't understand. My friends are talking about anti-aging, and I'm talking about, zits and how to get rid of them. And it's so frustrating for adults to have acne, but it's really commonplace now. It's not just a disease of teens. And when we look at numbers like this, I mean, it makes it feel like, well, maybe having acne is normal because it's so prevalent. But just because something is prevalent does not mean that it is normal. And what we've discovered is that it's really not normal for humans to have acne. And we know this through studying indigenous populations who are living today on the planet. So by this, obviously, I mean that these are populations who are like, in rainforests, and they have not taken on Western society. They're still in hunter-gatherers and not using kind of conventional Western products at all. So the Ashe people in Paraguay were studied. This is a tribe living in the Amazon. This is a group of 115 individuals. This population, the tribe was examined over 843 days, so like 2.5 years. And they could not find a single zit in anybody, not a papule, pustule, or open comedone. And there's men, there's women, there's teens, there's menstruating females. I mean, there's everybody, and not a single person had any sort of acne. Okay, maybe they've got some like amazing genetics going on in Paraguay. But we've also looked in Okinawa. So prior to World War II, Okinawa is of course the southernmost island in Japan. And back then it was pretty remote, and people who lived on the island were non-Westernized. It was a very kind of old school island living type of lifestyle. And questions were administered to the physicians who practiced on the island between 8 and 41 years. What's going on? How much acne are you seeing? How are you treating it? And the doctors were like, these people don't have acne and we don't treat it. And the Kitabon people from Papua New Guinea, another indigenous tribe, have been looked at. This is a population of 1,200 individuals. They were examined over the course of 7 weeks. And if we were a person, I'd ask, what do you guys think they found? And I think you guys know the answer by now. Nothing, goose egg, not a single zit in anybody. So these are pretty astounding numbers, right? And again, it's not that there's something genetic, amazing genetic going on, because when indigenous people move into urban places and take on a Western lifestyle, they can and do develop acne. So we really know that acne is a disease of Western lifestyle. So of course, our diets are considerably different than our indigenous populations, right? They're eating a lot of fiber. They're not eating our main things like meat, wheat, dairy, and sugar. But as we talked about, these are the mainstays of the typical Western diet. And we can see how all of them in different ways push on the mTOR pathway. So meat, dairy, and wheat are all high in the amino acid leucine. Leucine, as we talked about, is the amino acid that triggers mTOR complex the most. Dairy is, of course, triggers insulin-like growth factor and insulin, because what is the point of dairy? It is to make baby infant mammals grow extremely fast. So it's absolutely pushing on growth factors. And so when we eat dairy, it's telling that mTOR pathway, I'm a baby mammal, it's go time, it's grow or die, let's do this. And in an adult, what are you gonna go build? They've already grown. That can impact the sebocytes. And then of course, sugar, glucose is a driver, as we saw, of the mTOR pathway, and triggers insulin and insulin-like growth factor as well. So unfortunately, all of the things that we love to eat in our Western society are drivers of the mTOR pathway and are going to contribute to acne. But it's not just that, right? We have a myriad of influences on our gut microbiome. We talked about the diet, but the pharmaceuticals that we take and that are actually found in our water, where you live on the planet will impact your gut microbiome, where you are in your life cycle, how you were given birth to, how you were fed as an infant, were you breastfed or bottle fed, and just every factor of daily life, stress, do you exercise, your psychological state. So everything is impacting the gut microbiome. We know that it is quite different than indigenous cultures. Now, do we just shoulder shrug, oh, well, we're living in Westernized society, there's nothing we can do about it? No, of course, that's not the answer. So let's look at acne and some elements of the gut microbiome that we're going to be seeing in the case studies and that are particular to acne. So let's start with Candida. And Okay, so we're going to start with Candida. It's a yeast, a single-cell fungal organism. We know that Candida includes about 200 different species. It's a commensal. It's found, all over in our respiratory and gastrointestinal and female genital tracts. It's on the skin. But the problem with Candida is that when the mucosal barriers are disrupted or the immune system is compromised, then it can become opportunistic. It can invade and overcolonize or cause infection, right? Like a vaginal yeast infection. But we can also get Candida overgrowth in our gut. H. pylori, Helicobacter pylori, a gram-negative bacteria. It's an LPS, a lipopolysaccharide or endotoxin producer. We can see it here. It drills into the stomach lining. It has been connected with gastritis, peptic ulcers, and gastric cancer, but it's also linked to dermatological diseases like acne, rosacea, and other conditions as well. And while it is estimated that, up to 50% of people, if you just pull any, kind of controls, they can be infected with H. pylori. And I know there's a debate in the kind of naturopathic functional medicine world whether or not it's a commensal. I do not think it's a commensal, and I always treat it. In addition to the fact that it's been linked to these severe diseases, the reason why I don't like H. pylori is I see it in my patients and I think it's causing problems. And here's the problem I think it's causing. Well, first of all, as we said, it drills into the stomach lining, and that's obviously going to cause irritation and problems. But it is problematic for it that it's decided to live in the stomach, which is a completely hostile environment because of our stomach acid. And so it needs to produce urease, which is an enzyme that will combat the acidic environment of the stomach. And what the H. pylori is trying to do is trying to neutralize the stomach acid around it to create a buffer zone for itself to protect the H. pylori from the strong acids. Well, that is great for the H. pylori, but it is not so fabulous for us because it's going to affect all the things that stomach acid should be doing. So it's going to create suboptimal digestion. And not just while it's in the stomach. Of course, while it's in the stomach, if your stomach acid isn't acidic enough, you're not going to digest as well. But stomach acid is also a signal to the gallbladder and the pancreas that food is coming their way and that they need to produce, to inject bile from the gallbladder and enzymes from the pancreas for digestion in the small intestine. And when the stomach acid is impacted, we can get the ox bile and digestive enzymes impacted. And there's suboptimal killing power. The other function of nice strong stomach acid is that it is a killer. We swallow about 2,000 times a day. I think we know that our mouths are not sterile, right? You would not want your surgeon to lick your scalpel before cutting into you. That would not be a good idea. But even something like a glass of water, this looks clean, that it's got a ton of microbes, or food, every time we eat, drink, or swallow, we're just bombarding our immune system, our stomach, with microbes, and the nice punchy stomach acid will kill them off and neutralize them. Protozoa. Okay, these are single-celled eukaryotes. Protozoan actually means first animal. There's again a debate as to whether all protozoa are pathogenic or some are commensal. We're looking at this this critter, Giardia, which I think looks like an alien. It's agreed that Giardia is a pathogen, but there's other protozoa like Blastocystis hominis, Dientamoeba fragilis, for example, that some people, consider commensals. I do not. Protozoa can cause gas, bloating, and GI issues, but I treat all protozoa that I see. And I usually only see protozoa in my patients who have H. pylori. And I think that is that hypochlorhydria or too low stomach acid that we talked about because of the urease and other substances that the H. pylori is producing. It's making the stomach acid not acidic enough to kill off these protozoa when patients are exposed to them. All right, so how do we connect this all with acne and the gut, what's going on? So I conducted a research review of my patients and data because I felt like I was seeing much higher levels of H. pylori, Candida, and protozoa in my acne patients versus my other patients like eczema or psoriasis. It just felt to me like there was this acne gut situation going on. And but I wasn't sure, so I wanted to go back and actually pull the data on my patients. So I did a retroactive study, and I pulled the most recent 36 patients from my database with an ICD-10 code for acne. That happened to be 28 females and 8 males that I was treating for acne. Their ages ranged from 13 to 40, and the mean and median ages were 25 years old. And what I saw was that what I thought I saw was what was happening. So there was a lot of candida. 94% of the patients had elevated or high candida. 92% of these 36 had H. pylori present or high, and half of them had some protozoa. So it could have been Giardia, but it also could have been like a Blastocystis hominis or, other protozoa. And then in terms of how those broke down, 47% or almost half had all 3 conditions, and 44% had 2 conditions, generally being Candida and H. pylori. And just like I said, with the protozoa, almost all of them, 95% of those who had protozoa had, high or elevated H. pylori levels. So I really mostly only see protozoa in conjunction with H. pylori in patients. Now, of course, the question is, okay, so they have these levels, but how does this compare with, standard populations? So it can be a little challenging to get that data, but I tried. So let's look at the H. pylori first. So my acne cohort, 92% of them had the H. pylori. There's published research saying that healthy controls had 36%, but it can range up to 50. Diagnostic Solutions helped me out with this project. They went back and looked at 18,390 GI map stool tests for everyone who had tested. Now, of course, it's a little skewed because most people who are doing a stool test are having some sort of gut dysfunction, so they may have higher levels of H. pylori, but only 65% of all of those 18,000 had H. pylori. And then Biocanic is another company that kind of extrapolates data, and they had about 2,940, and theirs was 41%. So we can see that the H. pylori in my acne cohort was much higher than other controls. Same with the Candida and same with protozoa. So it seems like there is this kind of acne gut. Now, is there any research or data on H. pylori as it relates to acne? There is. Here's an example. There was a case-controlled study of 100 patients, 25 controls, 75 patients with acne, divided into mild, moderate, and severe. And what we see is that so in their normal healthy control group, 56% had H. pylori. So it's definitely not, oh, if you have H. pylori, you definitely have acne. That is not true. But what was interesting is that as the severity of the acne increased from mild to moderate to severe, we saw increasing rates of H. pylori infection. And this does come up a lot, that there is this H. pylori acne connection. So what is going on? Well, let's go back and visit our friend FoxO1. So there's a bunch of FoxO1 inhibitors, things like the Western diet, right? That's triggering insulin and insulin-like growth factor. And puberty, we have to downplay a little bit of FoxO1 because we need to grow. So growth factors of puberty will inhibit it. It also seems that P. acnes or C. acnes overgrowth can have a feedback loop and inhibit FoxO1. But there's a whole theory now that acne may be just due to the deficiency of FoxO1 within the nucleus of the sebocytes. Now remember, FoxO1 has to be in the nucleus to be active. So if it's in the cytoplasm, no good, can't control mTOR. If it's in the nucleus, it can do its job. And there's this whole theory that maybe it's just due to the lack of FoxO1 that mTOR is running out of control. Now, I tried to find information to see if there was any studies on, H. pylori and sebocytes. I couldn't find that. But what I did find is that there's a study showing that H. pylori infection induces nuclear inactivation of FoxO1 in the gastric cells. So H. pylori is kicking FoxO1 out of the nucleus into the cytoplasm and inactivating it in the stomach, gastric cells. It is possible that it could be happening in the sebocytes, although I would just reiterate that there's no research. It's just a hypothesis of mine for why we could see H. pylori connected with acne. All right, so let's get to the good stuff. Let's do some case studies and see how do we put this all together and how do we actually get clinical results for our patients. So we're going to start with this patient, and neither of these patient examples, it's not their actual name. So we'll call this person Emerson. This is a 30-year-old non-binary individual. They were assigned female as birth, and their preferred pronouns are she or they. And Emerson has had acne since she was 11 years old. Starting 3 months ago, it started to get really bad. She did have a period in high school where it was bad, but it was never been this bad. And we can see that this is quite severe inflammatory acne, and this is considered severe. Symptoms, painful nodules, and they said, I don't feel comfortable in my own skin. I can't stress enough that derm patients, this is not just a cosmetic issue. It is really, there's pain and there's societal norms and issues for them. And there's research showing that patients with these chronic derm conditions have increased levels of anxiety, depression, and suicidal ideation. And there can be prejudice against them in terms of like trying to go get a job at the workplace. It's really problematic. So this is a very big issue for this patient. And this patient has dealt with some, psychological issues, and they really feel that they're not going to be comfortable and feel well until this is resolved. They started seeing dermatologists at the age of 12 years old, and we can see that they've done it all. So like every topical you can think of, clindamycin, the topical antibiotics, salicylic acid, benzoyl peroxide, tretinoin, which is the topical vitamin A derivative, just, everything under the sun, not working. Orals, she took antibiotics, she took doxycycline for 3 months and did Accutane or isotretinoin. Did a course, but cut it short after 4 months for mental health, although the acne was starting to improve. But also Accutane is pretty toxic. We know it's teratogenic, and any female who goes on Accutane has to have a birth control test a month before, every month during, and the month after, and be on 2 forms of birth control and sign a pledge. So, if it's that toxic to developing fetuses, like, do we want our, developing teens on it, or even adults? A lot of people want to avoid that. They also did spironolactone at 200 milligrams, which is a very high dose, for 2 years. Helped, but had to discontinue for side effects. And again, this is all treating symptoms, not root cause. So yeah, the minute you go off of spironolactone, the acne comes back. Right now, they are applying a tazarotene cream 3 times a week, vitamin A derivative, but we can see that this is not under control. This patient was also diagnosed with PCOS and hirsutism, or unwanted hair growth in areas like on the breasts and on the face. So the next steps, of course, we're going to do a GI map, we're going to do an organic acid profile, and this patient wanted to do a hormone test as well because of the history of PCOS and hirsutism, so we did all 3. And just to see, this is where we're starting. So when we look at the GI map results, so not 100% of the time. So we can see this patient didn't come up with H. pylori, which, it's always interesting to me. And then most of the time I don't have to do a hormone test for patients, but when there's no H. pylori in an acne patient, I am kind of thinking, okay, I might need to look at some hormones, which we had already done in this case. We can see with the commensal bacteria, they're pretty good, but there's no Akkermansia muciniphila. This is my eczema gut looks quite different, and I did a talk for GI map last year, so you can go look at that. If you want to learn about eczema, you can look at that one last year in the library. I talk a lot about Akkermansia muciniphila for my eczema patients. We can see that there's some dysbiotic overgrowth going on here, a high amount of Enterococcus faecium, some Staph aureus, some Streptococcus, so we'll want to clean this up. And also an overgrowth of Candida in the gut, which isn't super surprising. On the organic acid profile, the only significant finding was that there was some Fusarium mold, so some more fungal stuff to deal with. On the hormone testing, there were some findings. So there was some high DHEA, high testosterone, high cortisol, and some low progesterone. So there was work to be done on the hormone piece. And when I run the labs, I like to kind of collate all the results together so that in my mind, I know, like, okay, here are all the issues that I need to be dealing with to treat the root cause of what's going on. So we've got the bacterial overgrowth, right? There's some dysbiotic overgrowth. There's maybe a leaky gut picture. There's no Akkermansia muciniphila. There's definitely fungal overgrowth. There's Candida and Fusarium. And there's some hormonal issues with the androgens and the cortisol and some low progesterone. Okay, So let's look at what do we do to help this patient. So the first thing is that protocols are always individualized. I'm a naturopathic doctor, and in naturopathic medicine and functional medicine, we always say treat the individual. So it's not like, okay, here's the plan I'm going to use on every acne patient. I have to go test and treat their gut to see what's happening for them. For example, a little bit of a surprise, this patient didn't have H. pylori, so I'm not going to be doing H. pylori protocols. The other thing is that plans change every 2 to 3 months. So I see patients about every 2 to 3 months for follow-up. And each time we have the visit, the plan changes and I move them through different elements. So what you're seeing here, what we'll go through is kind of like everything that was done, but it wasn't all done at one plan. That's kind of the art of this, is figuring out, okay, what do we start with and how are we going to move through different protocols. So for the bacterial overgrowth, I'm going to use, and I guess I didn't say that at the beginning, but as a naturopathic doctor, I don't really use pharmaceuticals. I would say like 99.9% of my plans are naturopathic. They're herbs and supplements and non-pharmaceutical options. So I treat with antibacterial herbs, our beautiful herbs, berberine, neem, oregano. For the candida and fusarium overgrowth, antifungal herbs, things like caprylic acid, Pau d'Arco, uva ursi. For the Akkermansia, there are Akkermansia probiotics, but also Akkermansia likes foods high in polyphenols. So those beautiful color groups, things like cranberries and pomegranates, that can help encourage the Akkermansia. For the low commensal bacteria, pomegranate prebiotics, so there's products that can help feed not just the Akkermansia, but the other ones. They basically contain what I mentioned, things like blueberry, cranberry, pomegranate. 35 grams of fiber a day. So this is really important. And I work with all my adult patients on targeting 35 grams of fiber a day. For my pediatric populations, it varies depending on their age. But adults, it's 35 grams of fiber a day. This is a lot more fiber than most people are going to be eating, and that's fine. I have them track it. We see where they're at, and then we slowly increase the fiber. You don't want to increase the fiber too quickly. It's going to cause a lot of gas and bloating and can actually cause constipation if they're not drinking enough water. But getting them up there, and 30 different plants a week. So the 35 grams of fiber a day and 30 plants a week seem to be these kind of tipping points for maintaining healthy gut microbiome. So we're working on this all throughout treatments. And I do have them track it for the first 3 or 4 days and send it to me, and then we work on it. For the high androgens, using some 5-alpha reductase inhibiting herbs like saw palmetto, pygeum, and nettle root. Of course, nettle root for this, not the nettle leaf. The nettle leaf is more for allergies and stuff like that. And for topicals, a variety of things, botanical topicals, to try to also inhibit that sebum production, but heal the skin, because you're going to see that scarring was a big issue for this patient. Now, of course, this patient is 30. They've had acne since they were 11. We can expect some scarring to be going on. So let's look at the progression of their skin throughout each visit. So this was the first visit. Now we're at the second visit. Now, hopefully you can see, I don't know how small your screens are. Obviously, there's still a lot of acne. There's also a lot of scarring, but this is exactly what I want to be seeing in my acne patients. It's not gone. It's not, we can't just wave a magic wand, but we have really turned down the dial on the acne, and there's a lot less active inflammatory acne. So we see the puffy red active spots. Here it's more like they've sank down. It's more like scabbing and redness. This is a healing process, and this is what I want to see every time. Then at the 4-month mark, we can start to see, significant reduction in the amount of kind of healing. There's still some active acne coming through. Again, it's not a magic wand, but turning it down even more. Now by the 6.5-month mark, we can see that most of the inflammatory acne is gone, and a lot of what we're left with is the PIH, post-inflammatory hyperpigmentation, and scarring, and we can see some divots in the skin. And something else to keep in mind is to treat beyond clearance. So when I first kind of was developing these methodologies and getting success like this, I would hit here and think, oh good, we're done, we can finish. And I would kind of stop treatment. And what I realized is there's that proverbial bucket, things that are filling up our buckets. And when it overflows, that's where we see the problems like the acne. And that right as soon as it cleared, I was lowering the bucket, low enough below the lid that the acne would stop. But a lot of times I was seeing patients coming back on my schedule like 4, 6, 12 months, and it was just they were right here and then it was overflowing again. So now I treat beyond clearance. Sometimes I retest depending on the budgets of patients, but don't stop just when it gets clear. And now you're going to see like a series of improvements. And this patient, like I said, they were really psychologically traumatized by the acne, and they just wanted to keep treating until clearance and wanted me to deal with the scarring. So now we've kind of transitioned a little bit and we're trying to work on repairing the skin. And again, depending on, what life is doing and what people are doing, you can still get a pop-up here and there. But you can see that by this point, dramatic difference, no pharmaceuticals, skin is repaired a lot. Even at age 30, once the inflammation is gone, if you're supporting them with nutrition and using the right topicals, the skin will repair itself. And if you look at like this to here, it's a big difference. So let's look at the other cheek, similar things. We're kind of going through some, this one actually, there was a little bit of pop-up on this side. It's okay. Now we can see it really kicking in on this side. And same thing, that the active acne is really turned down, but we're dealing with scarring, and now we're trying to kind of clean that up. And then here we've got just, a very different skin than what we started with. So that was this side and that's this side. So that was one patient. So let's go look at a second case. We're going to look at a 23-year-old male this time. We're going to call him David, not his real name. This patient, I don't think I need to tell you that we are dealing with nodulocystic acne on his neck and back. He's a 23-year-old patient. He has also had acne since the onset of puberty. He did doxycycline. So again, doxycycline is an antibiotic that's very commonly used. A long time ago, they used to put people on these antibiotics for like years. Now, with better antibiotic stewardship, at least it's more kind of banded to usually 3 or 4 months, but sometimes they'll be on it for longer. But a lot of times people will be on the doxy for the 3 or 4 months, the acne will get better. The minute they go off the doxy, it will come back, again, suppressing symptoms. That's not what we're after here. Tretinoin cream, so that vitamin A derivative, lots of other topicals, and he is actively trying to avoid the Accutane. He doesn't want to do it because he knows it's pretty toxic. So the next steps, of course, we're going to run the GI map and an organic acid profile. So his GI map stool test, he does have a high level of H. pylori. And in case you guys don't know how to interpret the values, 2.2 E3 is 2.2 times 10 to the third power. So it's 2,200, definitely high. A lot of my acne patients, though, will be in the E2 hundreds level, kind of more moderate. I still treat it. I still see that there's effects going on. And as we talked about, we see that H. pylori acne association, and it may be related to kicking FoxO1 out and letting mTOR get out of control. For his commensal bacteria, we're seeing a different picture. This is why I need to test every patient. Their guts are different. This is what I call an insufficiency dysbiosis profile. And if we look down here at the phyla, Bacteroidetes and Firmicutes, these two phyla together are showing us a snapshot of about 85% of the good gut bacteria in David's gut. And we can see that he's low overall, right? So this is particularly working on fiber and stuff is going to be important here. In his opportunistic or dysbiotic bacteria, nothing too crazy, some Staph aureus and strep, which are the most common ones that you'll see, a little Enterococcus faecalis. I think actually the insufficiency dysbiosis is a much bigger problem for him than this. But we see here his elastase, we're seeing the effects of that hypochlorhydria that I talked about. So elastase, we really want it to be 500 or over to be ideal. And his is at 254. And this is, I think, the H. pylori with the urease, basically creating the hypochlorhydria or low stomach acid. And this is where I usually see elastase problems or steatocrit problems. In this case, I think the pancreas isn't getting enough of a signal because the stomach acid is too low. And so it's suboptimal elastase. And usually when I fix the H. pylori and it's gone, the steatocrit and elastase will fix itself. We're also seeing secretory IgA, though. There's a lot of inflammation in his gut, so we need to calm down that inflammation as well. In the organic acid profile, the only significant finding was candida overgrowth, so he had that as well. So for him, same things, protocols are individualized, plans are going to change every 2 to 3 months. For his, other bacterial, antibacterial herbs, thyme, clove, and oregano, grapeseed, and neem. For H. pylori, again, I don't do antibiotic therapy, so I do things like zinc, masticum, bismuth, DGL, that kind of stuff. For the low commensal bacteria, I do use spore-based probiotics, pomegranates or the pomegranate powder, and again, working on 35 grams of fiber a day, 30 different plants a week, and using topicals for him as well to help clean this up. So for this patient, this is where we started, very pronounced, very bad nodulocystic acne, very painful for him and embarrassing. And just within 2 months, a dramatic decline. So again, this is what I'm talking about with like turning down the dial, and it's flat now and it's red and it's scabbed, but this is the healing process. So this is exactly what I want to see. And I know we're definitely on the right path. At the 3-month mark, we still have some of that post-inflammatory hyperpigmentation and scarring. This is very severe. It's going to take time for that skin to clear up, but we're only 5 months in, and that's, quite a difference. And then at another 2 months, I think it's hard. I don't think you would look at this individual and ever think he possibly had, nodulocystic acne like he did here. So a really huge improvement. And he was thrilled, obviously. On the back, when patients take pictures of their back, it's harder to get it. So I know this isn't super clear, but I think you can see some of these big nodules happening on the back and the neck. And then at the 2-month mark, you can see kind of, again, a dialing down, not completely gone, but not as bad. And then at the 3-month mark, just, a whole different back. And then 2 months later, the white is stuff that was on the mirror, but I think you can see through to his back and see that, it's much, much better. Okay, so what are things to consider if you want to treat this way? Well, when treating the skin, think of the gut. It's this overlooked area of naturopathic and functional medicine. I mean, I think we know, okay, the gut really impacts everything. And yet when we come to treating dermatologic diseases, not a lot of people are running things like a GI map stool test, and you should be. Analyze all the problems that you'll need to address with both, gut labs or all the labs that you run, kind of like the sheet I showed you. Decide what order you want to treat them in. Don't treat everything all at once. There's going to be too much. People don't, get to 30 or 23 with this kind of acne and poof, you're going to be able to treat everything in one plan. That's just not the way it's going to happen. Of course, you want to learn the best protocols to treat all the issues, both internal and topical, and adjust based on your patient. And then, like I said, I like to move through different protocols every 2 to 3 months, treat beyond skin clearance, as we talked about. And so this was obviously an example working for acne. Does it work for other dermatologic conditions? Like I said, you can go back and watch the eczema course from last year, but here's just some examples. So this is other nodulocystic acne, eczema, infant eczema, adult eczema, hand eczema, eczema herpeticum, psoriasis, it works great as well. It's a different patient with psoriasis. Guttate psoriasis on the back, palmoplantar pustulosis, scalp issues, hair loss, sebderm, all of it. If you are interested in learning more about this, I have a root cause functional dermatology course for professionals, and it's a comprehensive training course with 35 case studies. So like you saw these case studies, but instead of just kind of having a general page, you're going to see the exact treatment plan for every visit that I've given to each patient. So the exact orals, the exact topicals, and how I move patients through different protocols for different things. There's 7 of the most common dermatologic diseases that we go through: acne, eczema, sebderm, psoriasis, rosacea, hair loss, and keratosis pilaris. There is advanced functional medicine lab training in it, so I'm going to take you through the GI map and how to analyze it and treat, the oat, mycotoxin testing, Dutch hormone testing, how to treat conditions like H. pylori and SIBO, and much, much more. Just a note that Diagnostic Solutions has other tests aside from the GI map. They have an organic metabolomics, an allergy explorer IgE, and an IgG food explorer one as well. And that's the end of the information I have. So I'm happy to answer any questions if there are any.
Yes, there are. Thank you so much for that great presentation, Dr. Greenberg. We do have some questions for you. Okay, the first one is, can you describe how biotin can be a trigger for acne?
Yeah, we know more about vitamin B12 than biotin. With vitamin B12, high dose vitamin B12, that C. acnes or Cutibacterium acnes that lives on the skin, it's eating the sebum, and the way that it metabolizes and processes the sebum gets skewed with the high dose vitamin B12 supplementation. With the biotin, we're not sure as much, but biotin, biotin is one of those things a lot of derm patients come on, especially for hair loss. And I think there's this notion, well, if I just throw a ton of biotin at myself, it's going to fix it. And the research doesn't support it. So even with hair loss, there are no studies showing that high dose biotin supplementation in the absence of deficiency will help with hair loss or hair growth. So it's one of those things where like people are taking the biotin, but again, unless they're deficient, which most people are not deficient in biotin, it's not helping and it can be hurting.
Thank you. Do you treat H. pylori when you see it even at very low levels?
Yeah, I treat all H. pylori. So even in the E2, a couple of hundreds, it might not be the first or second or third thing I treat if it's like, down at 100, but eventually I am going to treat it because I find that H. pylori tends to go in one direction, which is up. And I like to treat it down.
Thank you. When you see low levels of Candida on the GI map, do you also treat it when the patient is presenting with acne?
Yes, I will always treat the Candida overgrowth as well. I mean, I think the nice thing with treating with herbs is, it's not like pharmaceuticals where, it's really going in with a heavy hand to one particular thing. The antifungal herbs, they're also antibacterial and antiviral and antiprotozoal. And, while we do have certain herbs that are better for one thing or the other, it's a much more gentle process. So I do like to make sure that the Candida is down and in control. And I don't like it showing up on the stool test because I feel like it's probably overgrowing at the back end. And a lot of times when I see it, I'll ask patients, do you have anal itching or vaginal yeast infections? It can kind of track around and cause those issues for patients.
Thank you so much. Can you explain how leaky gut contributes to acne?
So I don't think there's as much of a connection that I know about with leaky gut specifically for acne as much as like with eczema, and I go through that in the eczema talk. But in general, leaky gut will drive inflammation, and I do go through that in the eczema course if you want more information on it. So I think it's just the general inflammation, and we saw like one of the patients had high calprotectin, and we saw that inflammation drives mTOR. So I think through that pathway, but I haven't seen specific research on leaky gut and acne in the way that I have for like eczema. I think it's just the inflammation that is causing, we're not supposed to have a leaky gut.
Thank you so much. Do you suggest other dietary changes other than polyphenols and fiber?
Yeah, so when we talked about the drivers of mTOR, I pretty much take all of my acne patients off of all dairy, and they want to know, is it like, oh, what about goat and sheep? I don't drink milk. And then they think that's not dairy. But I ask, do you eat cheese, yogurt, ice cream? Oh, yes. Well, that's dairy. So I make it very clear. Any item that originally came from a mammal mama and was turned into something is dairy. So not coconut milk or almond milk. If they want, they can have that. But yeah, I take all my patients, acne patients, off of dairy, at least to start. Once they're clear, they can try and see how they do with it. The GI map also has an anti-gliadin IgA marker, and if that comes up high, we try coming off of gluten to see if that helps as well. So those things, but I find that when I focus on 35 grams of fiber, one of the nice things is people get so filled up on fiber and good things that there's less room for the not so good things. So naturally, they start eating better and less of the bad things. Of course, we talk about alcohol and sugar consumption, and depending on the intake of the person, whether that needs to be adjusted. So, it's naturopathic, whole person health for sure.
Thank you so much. That's all the questions we have for today. We'd like to thank you for attending today's webinar And thank you, Dr. Greenberg, for a great webinar. Have a great rest of your day, everyone. Thank you so much.
Thank you.